and hardly visible on the left side. And right side also. But the patient came with inferior SKMI and with thrombolysis, this inferior RC also diffuse disease. And that is LIMA, that is triple vessel disease, critical life disease. And in the meantime, what is the now option? It is the emergency CABG or emergency PCI. If PCI is done, which one is? Culprit artery, there is culprit artery is RCA or left main. But immediately after doing CBG, where we talked with the patient's party, patient developed cardiac arrest on the table due to PF, and we managed with cardiac resuscitation and DC cardioversion. And patient shifted to CCU, patient developed recurrent BPPF, and he was put on amiodarm. And consult with cardiac surgeons, including me and also patient's party, or 2 or 3 hospitals, they consult with cardiac surgeons, nobody was willing to do surgery. They refused to do surgery. And patient is still on hypotensive, he was on inotrope, we put on central line, and on third day, creatinine level got patient developed AKI. And that, so what can we do? Nothing to do, surgeon will not do anything. If we can, so after consultation with the patient's party, they gave consent for rescue PCI with high risk, but we can say the patient may die on the table also. Because, and now after patient's party was agreed for the PCI, and what should we do? Culprit artery or left main? Then in the excellent study, there is a PCI procedure. If RCA has severe culprit lesion, but if there is associated left main lesion is less than 70%, then we can go for culprit artery. But if there is critical left main, so we should go left main before the RCA. Then what are the challenges before doing RCA in this setting? Patient is very unstable. There is ongoing chest pain, he was on hypertension, multiple inotropes. Age of the patient is 70 years, their likelihood of calcified lesion. LV injection pressure is very low, patient developed AKI, so again amount of contrast should be kept. No mechanical circulatory support and no imaging facilities in our center. So we go for left main stenting, this transfemoral, and before we preloaded with the guide wire with the balloon initially from the very beginning, because as soon as we cross the lesion, we have our attempt to pre-dilate the lesion. Anywhere goes, and then we pre-dilate the lesion. And after pre-dilatation, there is some flow is visible, then we put another wire in the LCX, then there is a lesion, you can see, then after pre-dilation, we deploy the stent 3.5 by 38, and targeting stent was put on left main to LED, including ostium. It was nicely deployed, luckily. And then port was done with 4.5 by 8 balloon. Then this is the final result. This is the final result, and LCX and LED was well vascularized. And immediately after procedure, patient will become regularly stable, and inotropes are withdrawn within 48 hours. TPM can be removed on next day, and LV was controlled, and he was no need of oxygen, and creatinine level will become normal. And patient after 7 days, PCI was 2 RC was done transradial on elective basis. It is a just normal basis, transradial. RCA was done. This is a provisional stenting. Nothing complicated here. So take home message is unprotected left main PCI is a life-saving procedure and always challenging, and proper planning and teamwork is very much essential, especially in setting up where their facilities are not available. And procedure in this case, as you follow, keeping it very simple and safe. And every patient should be treated individually, and it depends on every clinical judgment, available expertise, cost and stillness of the operator. So thank you very much.
Thank you, Dr. Ashish. That is a great case. You did that tab, ultimately, you did the tab. Who is bifurcation listed you did, yeah? You did the left main to LCS.
Ashish, use the microphone. Use the microphone. Only left mid to LED cross over stent.
So he did a provisional stenting of the left main to LED. I think excellent, Ashish. This is a fantastic case.
Crossing and I did not cross the LCA system. I did not do
Dr.
any
Ashish,
kissing.
excellently done. You have in acute coronary syndrome to do a left main PCI brain. You have done excellent job. What was the ECG findings? Only sinus bradycardia?
Only inferior STMI, 2-3 IVF, and
There is
also
no ST elevation in inferior leads.
there is diffuse ST depression in other leads.
The certain culprit is the left main. Thank you. Thank you. Next.
Ashish.
It's great job. Thank you very much. Excellent case. Yeah, I think at the first time you may also consider to do PCI because this patient has no other choice. If surgeons refuse it.
Because at that time when we talked with the patient developed cardiac arrest on the table.
Yeah. So
Speaker and VTPF, we have to manage the patient first.
yeah. Very good job. Thank you.